Future basically here, and I want to kick off with the first speaker. It's Professor Bellucci from Verona. He is the past president of the ESCRS, a big-time name in ophthalmological education, has more than 30,000 cataract surgeries to his name, and many very nice and innovative ideas. He's going to talk to us about the Intensity pentafocal lens. Please, Professor Bellucci.
Thank you for this nice introduction, guys, and happy to host you in my homeland, Italy, and in Milano in particular for this interesting symposium. I have to tell you that, oops. Yeah? Great. I have to tell you that I was amazed by the Intensity IOL. You see the characters of the IOL here, but probably other speakers will speak in detail about that, because it truly has, the last line is the most important for me, an innovative diffractive design. What does this mean? This is a pentafocal lens where the distant focus is obtained through diffraction. This is not the only lens obtaining the distant focus by diffraction. There are others, but this is the only lens having a 5 foci and a twice application of the principle we learned about the intensifier, how to intensify foci using the first order harmonic focus. This aberration study in particular I'm presenting today compared the pentafocal intensity with the trifocal fine vision IOL, a very good IOL that used to be my preferred. And these are the main difference between the two IOLs. We have the refractive focus is the distant focus for the fine vision. However, it is the intermediate focus for the intensity. And so I wondered how this might impact the postoperative refractive results and aberration in particular. For this particular study, I considered 20 patients per group. After cataract surgery, the corneal astigmatism had to be low. Binocular implants, the age were very similar were the axial length and the other parameters, and we have more than 6 months follow-up for all the data presented here. First important data, the automated refraction. We know they do not work with multifocal lenses, but especially they do not work when multifocal lenses are of complex technology and use diffraction to obtain the distant focus. So for the intensity in particular, a sort of myopia appears at the autorefractor that does not exist, while the astigmatism values are pretty nice. So first, if you have a minus 1.25 in your post-operative intensity patients, that's correct. They are not myopic. About the wavefront refraction, as you know, we can obtain refraction out of a circle and not out of the circumference by wavefront measurements, and we obtain the same both at 3.5 at a 5 millimeter aperture diameter, the intensity providing myopic result in a sphere as compared with the fine vision. What about high order aberration? Well, nicely, it seems that the implementation of 2 additional foci did not impair the aberration result as far as high-order aberration are concerned, and also the spherical aberration Z40 was pretty the same as compared between those 2 types of IOLs. The Z40 was slightly negative with both types of IOL. What about coma? As you know, coma is not a vector, but it is represented as a vector, And so we need both the absolute, the actual figure and the absolute figure. The absolute figure meaning that if the comma is in one direction and the other eye is in another direction, the net result will be 0. But if we take the absolute values of comma, it will not be 0, it will be a little bit higher. Again, no difference between the intensity and the fine vision. For all these measurements, I took the 5 mm optical zone because aberration at 3.5 millimeter optical zone are very, very smaller. And so to find out if any difference would be, we need something more, something larger. So the trefoil, the actual and absolute values are quite different, because even here, when the absolute value is taken into account, the difference is not existing, while it seems that at least with trefoil, we have one preferred direction with the intensity. This data regards the double pass OCAS aberrometer. That is, the OCAS aberrometer, as you know, does not only consider the shape of the wavefront, but also the intensity of the wavefront. This is to say, if we are in Milano here, if we see a building through the fog, the shape of the building is perfect, but we can barely see it. And the OCAS will tell us there is a fog. And I was very curious because this is related with corneal transparency and intraocular lens transparency. And so we went through the OCAS scattering index, again the same. We went through the width of the MTF curve at 50% of the height and at 10% of the height. Again, showing quite better results with the intensity, but those results were not statistically significant. And this is the stray ratio. The stray ratio is a number, and actually it is a percentage of the optical quality of that particular eye referred to the maximum optical quality available. Again, we found no difference between those two lenses. But the OCAS mean, these are related with MTF, and the MTF cutoff were exactly the same with the two types of lenses with no difference. What about this photopsia and night glare questionnaire? We found slightly better results with the intensity as for halo starbus, but I like to say that the addition of two foci did not lead to an increased figure of this photopsia and night glare with the intensity. Actually, it seems that those figures are on the decrease as compared with the fine vision IOL, but this requires further investigation with probably different types of devices. In conclusion, the intensity IOL induced a wavefront refraction that depended on the intermediate refractive focus. The difference between the wavefront refraction at 3.5 and 5 millimeters was the same as that of the fine vision IOL, because the spherical aberration is pretty similar. High order aberration and spherical aberration were the same, and measured spherical aberration with intensity IOL was 0.117 at 5 millimeters in this study. Coma was very low and similar with either IOL. Trefoil was higher with intensity only when the angle of rotation was not considered, otherwise it was exactly the same. And the double pass measured the scattering index and optical quality and similar with either IOL. And night photopsia was a little bit lower with the intensity IOL. So a very promising lens that produced a seamless vision. I didn't speak about the very flat defocus curve, others will do, but for sure this is a major step forward in intraocular lens technology. Thank you for your attention.
Thank you, Professor Bellucci, for this wonderful talk and reiterating basically the results that we're all of us finding. I would like to keep these questions to the end, and I'm inviting Professor Noguchi from Japan, Kobe, Japan, to talk about his experience with intensity. And I'm excusing him already because he has to leave to catch his own flight, okay?
Thank you.
Please.
Thank you for introducing. I'm happy to stand in here. Let's start my presentation. I'm Santaro Noguchi from Japan. I'm talking about the visual function of high focal length comparative outcome. Short disclosure. I'm talking about the DFR, technical synergy, and intensity, Hanita, and the fine vision. There is no difference between them in background. At first, I will talk about the visual acuity in clinical study in the hospital. Those lenses have a very good visual acuity, of course you know, but intensity have a very good visual acuity monocular, especially in the 1 meter to 50 centimeter, very good visual acuity because of its high foci. If you implant both binocular, the intensity have very good accelerated binocular implanted, so more better visual acuity to 5 meter to 50 centimeter, 40 centimeter better than another IOLs. This is a wearing glasses rate in neo Japanese patient. Of course, you know the DFR is very good outcome for the wearing rate, but I'm surprised about it. Intensity had a more good result about it. Around about 90% patient don't wearing glasses for near. So, but we have to consider about the near vision. Patients see in daily life, not in the hospital. So they see several circumstances: newspaper, mail, PC, cell phone, dim light, long-term near work. The orange is the intensity score. The low score is very good. So intensity score is very low. So especially PC, cell phone, and dim light, long time, and near work is very good score. In summarize, and doing a large score, the intensity score is very low compared with another lenses. So intensity patient feel comfortable in daily life near vision. So we should have to consider the contrast. The multifocal unsatisfied multifocal IOL patient cause of most of the contrast sensitivity. The intensities contrast sensitivity is very high compared with another lenses. I've ever implanted a lot of multifocal IOLs, but compared with this, intensity score is best one. So I want to talk the pupil. This is my cataract surgery patient, over 50,000 patient eyes. So younger patients are bigger the size pupil, of course you know, but I want to say that the most median patient have a 2.84 millimeters pupil size in photopic situation. So human being have the accommodating reflex. So we see the ocular do accommodation reflex like accommodation, meiosis, convergence. So it means the in photopic pupil size is around 3 millimeter, 2.8, but we see near the pupil size diameter becomes smaller. I made the real model eye. It can choose the spherical aberration, aperture size, tilt, and dislocation. So I made the choice the Asian patient's model eye. So I chose the 2, 3, 4 aperture size and take a photo target. This is the result of the intensity with 3 millimeters aperture size. I'm surprised about it because it has a very good continuous clear vision from the 0 meter, 0 far vision to the minus 3.0 vision. Especially 0.0 diopter and minus 2.0 have a very good high energy power, light energy. How about the 2 millimeter aperture size? Very different from the 3 millimeter aperture size. it can energy, far energy is very decreased, and then near around the -2.0 diopters is very high. Energy power is very high. Change the energy, light energy. How about the 4 millimeters aperture size, intensity? Very different from these. The far energy is very high, become very high, and the near power is very low. But we can see near. But the high far vision is a very good and good contrast. Its intensity can have a good visual acuity and contrast in 4 millimeter aperture size. This is the model eyes defocus curve. 3 millimeters apertures are of course very good at the 4 and at the -2.25 to 3.0 diopters are very good clear vision. And when we see the near, accommodation reflex, the pupil size is smaller, the intensities can move shift the near. The near vision is very good, become good. The near visual acuity very good. So if we see the far at the aperture size 4 millimeters, the far energy is very good, and the far visual acuity is very good, and the contrast become good. You know that this is the official site, official web, the Hanita's. With 3 millimeters aperture size, far focal energy is over the 50% energy. But you will see that at the 2 millimeter apertures, change to the energy. So near energy over the 55% energy. So intensity can shift the energy with the pupil size. It behaves like accommodation. So this is the additional slide with model eyes with glare. Intensity has very low glare. Because of the big, smaller size, it can, the energy goes shift to the far. Near energy is very low. So the glare is very low. So compared with another multifocal IOLs, don't hesitate with glare. Thank you for attention.
Wonderful and amazing that you make your own eye model and photograph it like this. I think that's really innovative. So the next speaker will be Professor Bianchi from Argentina. He's a cornea and cataract surgeon, has done a lot of innovative surgery, and he will speak about his intensive experience. There you go.
Hello, everyone. Thank you for coming. Thank you, Hanita, for your invitation. I'm so happy to be here with this great panel. Well, I will start with my experience about intensity. I think now we want to have all-terrain car because we want to have this experience to move around the world with the same car and to do everything. But also we want to have very good vision for far, for near. We want to have all-terrain eyes. And this is coming. And this is my experience with Hanita. I choose Hanita because I like Hanita, and I put more than 5,000 IOLs in my patients. And this is my experience from 2016, and now with more than 500 intensity and toric too. Well, now I will talk about something of intensity. What Hanita said about intensity, the main aspect, the maximal capability of using different light level, dynamic light utilization. What is that? It's because the apodicite design is symmetrically distributed in 5 focus size from intermedia. This is one of the most important things that intensity Hanita do this innovation about. This lens just lost this 6.5 of energy, but utilized 93.5% of energy. There is another main characteristic of the lens. It's the same spherical aberration that the other spherical lens from Hanita, and the posterior surface is aspheric and diffractive, and the anterior is spherical, and well, all the other characteristics that we have here. But like the Dr. Santaro said before, the energy distributed for the photopic pupil 50-50 and for scotopic 60-40. And this is, like I said before, that this lens is made from zero, the zero is intermediate. And it has for far vision, for near vision, but also this lens has two intensifiers for far and for internear. But another thing is the diffractive rings give to the distant and near vision, and the intermediate vision is given for the refractive rings. But I think really I will evaluate in my patient what happened. This is my study in my cataract surgery practice. I always test and evaluate safety and efficacy. And with the patient satisfaction, I make some questionnaire. This study is just published in the Indian Journal of Ophthalmology, and also you can find it in PubMed. It's about the intensity. And it's a prospective case series study with 6 months of follow-up, 56 patients, 112 eyes. I made the surgery with femtosecond, and I study efficacy, safety, and satisfaction, like you see here, spherical equivalent, the focus curve. I choose also the constant 118.4 for the Barrett. The lens come in this packaging, and with the sterile water, and well, you can see here how I put inside of the cartridge. I always put the optic over the optic. And of course, this lens has, this injector has this pusher to be sure that it will introduce perfectly inside of the cartridge, and then I inject gently inside of the bag. I always clean, always over and behind of the lens, and the lens look like this. Well, what happened with the focus curve? I found this the focus curve after 6 months, with 6 months of follow-up. It's really steady, the focus curve, and we here can see how it's for far vision, for near, and for intermediate. And also, I think that we see here the intensifier that the house of Hanita promote with this lens, with very good far, near, and intermediate vision too. And also the refraction after surgery, it was between plus and minus 0.5, and the safety also was very good without any complication. The standard graph, I gain, with our patient gain lines after surgery, and we don't lose any lines, and the refraction also you can see here, which was. And I make the satisfaction questionnaire, and I send to the patient anonymous. It was the way that I send it. And the first question is, after 6 months, did you obtain spectacle independence? And 94% say yes, and it's very good answer. And the second question, after 6 months, did your surgical outcome meet your preoperative expectation? And 100 say yes, and it's very good too. And another question that I did is this one. You can see in the little video how the dendrites connect, and they need time to do that. This is like we call in the pandemic new normality. We need time to adapt to these things. No, and 85% say no after 6 months, and this is important. And just 12% say sometimes, but they don't bother me. And conclusion, safety, no intra or postoperative complication, the efficacy, objective and subjective was good, and the time, always we need more time to study these things. Well, I have some experience with the toric, intensity toric 2. I presented this in one journal in Argentina. And this is the focus curve is similar to another that we see, but I have just, this study is with just 7 patients. I'm making another study with more patients too.
I am Nora from Buenos Aires, Argentina. I am 65 years old.
I don't know if...
15 days ago, I underwent surgery because of cataracts. Dr. Bianchi implanted intensity intraocular lenses in me, and now I can say I am another person. I can see everything. I can read the smallest letters of my cell phone. I can drive. I can read the newspaper. Everything. The only thing I can say bothered me a little bit was the hill of light I saw at the beginning, but it went away soon, very soon. Now I need nothing to see whatever I want to see, no matter the distance. I feel free, happy, and so grateful.
Well, after this video, I operate the distributor of Argentina, and I put 2 intensity in his side. His name is Silvio Rosinot, but well, he's cool too. I invite all of you, if you want to go to Argentina, to Ophthalmo Córdoba. This is the web page to go, and it's a presential and also virtual Congress. I am one of the directors, and thank you very much for your attention.
Herman, thank you. That was a very nice talk, and especially your patient. She's, giving the example of how our patients look like after surgery. So the next one that I would like to introduce is my dear friend, Ehud Assia, Professor Assia from Tel Aviv. He's a great innovator. He has several patents and devices that already went to the market. He's one of the best cataract surgeons in the world. You should see his videos, but now we should hear his talk. Please.
Well, thank you, Ruti, and thank you, Hanita, for inviting me. I did the first study on the intensity, and also a user of the intensity, but right now I will talk about some other thing, and this is a capsular anchor. These are my disclosures, and the capsular anchor is a device that we designed many years ago, and it is for positioning and scleral fixation of eyes, which has subluxation of the lens. The idea is that it looks like an anchor, and actually this is what it does. It anchors the capsule to the scleral wall. It works like these 2 lateral prongs are located behind the anterior capsule, and the central rod is in front, and here it is suture fixated to the sclera. And here's one example, and this is the first generation of the anchor, the older one. In this case, the patient had just a slight deviation, so we could do a femto also in this eye. Now I insert the 6/0 Pro lens through the main incision and externalize it at where I want it to fixate it to the scleral wall. The suture is now going through the hole at the base. We create a flange, need to make sure that the flange is not smaller so it would not flip out. Now we rotate, and note here that I'm implanting the anchor before removal of the lens. So actually, it will act as 2 purposes. Number 1 is to stabilize the lens during the phacoemulsification, like we use capsular anchor. And number 2, it will stay there forever as a permanent fixation. So now, after we have this permanent, temporary fixation, we can remove the lens, put an intraocular lens in the eye, and I like to put the lens in such a way that the long axis of the lens is aligned with the anchor. And only now we can do the last adjustment to make sure that it's well-centered and well-positioned. So this is the older version of the anchor, and we have tens of such cases. Here's another example of a patient after trauma and after fixation with the anchor. And we have, as I said, tens of cases. This is different from the Sion ring, Ahmed segment, and so because there is no equatorial ring. It is just this segment that is fixated to the scleral wall. If there is a very large dehiscence, one can use 2 or 3 anchors in a single eye. And this is subluxated lenses, which can also be repositioned using the anchor for lenses that were implanted many, many years ago. But we had a feeling that this device is kind of bulky, it's thick, it's wide, and it's uniplanar. And it was sometimes difficult to manipulate and bring it into place. So we designed a second generation anchor, and this is what it looks like. It is thinner, it is more flexible, it is more intuitive, and most importantly, it is three-dimensional. So there is a gap in between the one plane and the second plane. So here we can see the difference between the two devices, and it's much easier to insert the capsule here than it is here with this additional hole for better manipulations. So we started with laboratory studies. This is what it looks like. This is just a model. You can see the gap in between the two levels. This is a pig eye. We just insert it like a arrowhead, and we just place the anterior rod on top of the capsule and push it posteriorly and forward, and this is it. So you don't need to manipulate. We can also insert it when it is closed through a paracentesis, actually 1.2 or 1.5 millimeters, and do the same, and then suture fixate it to the scleral wall. This is the patient after trauma. So the most challenging part is to do the right capsulorhexis. Then we insert the needle and put it out through the main incision, thread the suture through the hole at the base of the anchor. This is a new anchor. We create a flange which is big enough so it would not flip out. It sets the anchor into the eye, and again, note that we do it before we remove the lens material, so it will also support a removal of the lens. And now it is in place, placing on top, pushing posteriorly and forward, and it goes right into place. We now do a temporary flange, and you see how it supports both the equator and the capsulorhexis. We now remove the lens material with phacoemulsification in a routine way, implant the intraocular lens, and makes the final adjustment only after the lens is in place, so we can make sure that we are well-centered and well-positioned. We need to make sure that the flange is covered both by the conjunctiva and tenon, but you see how well it is now fixated and centered. And this is after 1 month, the flange, the one single flange covered by both the conjunctiva and the tenon. This is another case of a trauma of dislocated lens, unstable. In this case, it was stable enough to do the phaco before implantation of the anchor, but you can see here on the side how much of the zonules are missing here. So this is where we want to have the extra support. Insert the 6-0, so the eyelet, make a large internal flange, put the anchor inside, and then place it. Now it's quite easy to place it when it is the bag is evacuated, so it's quite intuitive to put it in. Put the lens in. In this case, he also had a fixed dilated pupil, so we had to fix his a huge pupil, also by suture fixation. And in this way, we also covered the anchor. And this is what it looks like at the end of surgery. And this is what it looks after 1 month. We do not see the anchor here, but when we do the transillumination, then we can see, and here, note again, it supports both the equator and the capsulorhexis, and actually the entire segment. So it's not just a pointed fixation. And this is an IOL that it was implanted many years ago, and because of pseudoexfoliation, it was very unstable. So first we create a space in between the capsule and the IOL, place the anchor in place on one side and put it up, make a temporary flange, and then we open up in between the capsule and the IOL on the other side, insert a second anchor, and this is the right way to put it in, like an arrowhead, and make sure that the two lateral prongs are located behind the capsule. And now we finalize by adjusting the flange, make sure that these two lateral arms are properly located. Even though one arm can be enough, but we would like them to be symmetrical and provide a wide contact. So this is what it looks at the end of the surgery. So just as the bottom line, this is what another example, the wide attachment with the equator and the capsulorhexis. So this anchor is effective as a capsule stabilizer for a variety of subluxation, both crystalline and intraocular lenses. And this second generation modification provides significant improvement in terms of safety, efficacy, and the simplicity of use. And we may come even with the third generation, which is more applicable for the IOL dislocation. And I thank you very much for your kind attention. Thank you.
Wonderful. I didn't say one word too little, I think. So please, questions from the hall. Yeah. I will repeat it for everyone. So, is there any situation where Professor Assia will also put in a capsular tension ring with the anchor?
Well, the answer is absolutely yes. Yes. I mean, but then you have two functions. One is to fixate the capsule, and this is done by the anchor. And the capsular tension ring, the intention is to maintain the round contour of the equator. So if there is a large dehiscence of the zonals and uneven tension of the zonals, yes, I do, and I do it quite often. But I would like, prefer to separate between the ring and the fixation to the sclera. But yes, absolutely yes.
Okay. Just one more and then...
Yes, actually, well, okay.
The
question was, would CTR reduce the fall that we may see? The answer, again, is yes. Yes, it may do that, even though falls are not a concern, and usually you do not see them after some time because of the shrinkage of the capsule. But yes, it has a potential to reduce the falls.
So I would like to ask Professor Bellucci, now that you have this experience with the intensity of actually very good wavefront and barometry results, and also the visual results, has your practice changed in which patients you include for this intensity lens or other lenses? In what way did it change your practice?
The practice has changed a little bit because I frequently faced the complaints about the intermediate vision, even with those lenses providing some intermediate vision, but apparently this is not enough. And especially hard computer users, they have two computers and placed with the screens placed at different distances, and I frequently meet people telling me, doctor, I have to read documents, then I have a small computer, and then I have a big one. How to cope with such several distances? And I found that a trifocal lens is not enough. A pentafocal is.
Because of the higher the focus curve, the plateau that we see. Now, Ehud, do you have any tips, practical tips on how to implant or how to fold these lenses, or is there any practical tips that you would give the audience?
Well, luckily, no, because this is the platform is the same. So the two platforms that are in use today, the C-lens and the Vistor, which is the toric version, are lenses which experience of many thousands. So implantation is not an issue. The lens is the same as any monofocal lens, so it doesn't mean that you need to do anything different in your regular practice.
Okay. And in terms of halos and glare, how do you experience your patients' experiences, Bianchi?
Like I said in my questionnaire, I think that the halos disappear because the neuroadaptation with this kind of lens is easier and is not more difficult than another. I think it's easier than another. It was my experience, and I was surprised with this questionnaire that I made, because after 6 months, 85% say no, they don't think in halos, and it's very important for our patients.
So you have a high patient satisfaction.
Yes.
Right.
Yes.
Are there any more questions from the audience here? Please. Yes, the question is that because of the optical design of the intermediate being refractive and the distance diffractive, that the adaptation to the distance vision takes a longer time.
Actually, no. We should keep in mind that there is one lens in the market that has no refractive focus, and this is the Symphony. That lens has no refractive focus, and with pretty good results, so I don't think so.
Please.
In our experience, there may be some, I'm not sure if this is adaptation, is the right word. Adaptation we do see for glare and halos, but as for refraction, there can be some change. And we did observe occasionally that refraction improves with time. So you start up for 1 week, it's good in 90%, but then give it just a few more days or weeks, and the results are even better. So it may occur occasionally. But I'm not sure that this is because it is refractive-diffractive optics, but we may see it, some better vision after some time.
Actually, Leo has published this several years ago, that he looked at visual acuities over time using these kind of technologies, and he has shown that even though that the visual acuity may be very good right after surgery, 5 years later, these patients even improve. So there is a learning curve. I'm not sure you should call it a neuroadaptation, but unless they're the same, right? I usually tell my patients, you know, it's like walking the stairs. You take 1 step and 2 steps, you learn the distances, and then you run up the stairs. And that's the process that they have to do with intraocular lenses, basically. Any other...
Can I comment to that? Because we talk about neuroadaptation, and neuroadaptation is real. This is not a myth.
It's real, no?
We should not... we should differentiate between halos and refraction. And this patient, we asked them, how do you feel after surgery? And oftentimes, patients say, now that you are asking me if I have halos or glare, then yes, I can feel it from time to time, and then it disappears. And this is for real. And we see it when we do the second eye. You ask him, how do you see now? We say, now I have the halos and grays that I used to have in my other eye. Now, physics is the same. Physics did not change, but his feelings changed. So neuroadaptation does work and does exist, and patients, if you don't ask them, oftentimes they would not complain. They would not even feel it.
Actually, the best tip I have to avoid halos and glare is do bilateral surgery. Somehow it causes a reset moment, and the next day the patients come back and they say they don't even remember they had them. They have no reference anymore to their old eye. So this is, in my opinion,
and don't ask them. If you ask them, they will say, yeah.
We ask them, we do. Okay.
May I only add just one small item, that the size of the halo depends on the dioptric difference between the distance and the near focus. So if this difference is higher than 3 diopters, the halo will be wider.
Yes.
As regards with the intensity of the halo, it depends on the light distribution. It might be better with the intensity because of the 5 foci.
I think this is the real big innovation about the intensity, and I also think that we need to take into account all the eye, not just the refraction or the halo. We need to take into account how is the surface of the eye, the corneal refraction, how is, if there is some astigmatism, we need to correct. Everything is important when we use some lens like that, some premium lens, no?
So, any more questions in the hall? Okay, now, how many of you have already had experience with this lens? Okay, a few. And how many of you are now considering? Okay, that's some more. And you know, if you need any tips, feel free to contact us. We'll be happy to help you. Now, there's one characteristic of this lens that I like very much. I have had to use it twice in my whole career, but it's the fact that the optic and the haptics, they have a 5-degree angulation. So this is basically the only one-piece lens that exists that can be placed in the sulcus. So if you have a problem on the way, you have to know that you can place this lens also in the sulcus. You will get a little bit of more myopization because your optic will be a little bit forward, but this is a very nice tip for just about when you are going to get into trouble. Udi, any other tips that you have?
Yes, one other comment that I would say, we've been using trifocals. I think trifocal are revolutionary. I mean, they are game changer in the last 10 years from what we knew in bifocal or monofocal lenses. But, and we've been using hundreds of them from other companies. What is special with the intensity is the near vision and intermediate. This makes the difference. And oftentimes with other lenses, near vision is okay, but not perfect. I mean, I can see, but I cannot read freely, and so on. And there's a need for much more illumination with other lenses. And here with this lens, the near and intermediate are, for some reason, far better. And the illumination is good. You don't need a lot of light. So it does make a difference between these lenses. And I think this time, it's a hit. I mean, it's a very good lens. And practically, excellent results.
The amount of light that this lens lets through means that they need less light for reading as compared to other lenses. And this is really a wow effect, you know, that's really impressive. Anything else?
I always say to my distributor in Argentina that he has two intensity and he can read very well and with a little letter.
I heard he can read in the dark, so yes. I want to see the video of that one, right? I heard this.
I want the intensity in my eye too.
I heard this. Reading menus in dark restaurants with a pentafocal lens in. That's impressive. I need to see the video. Okay.
And with a mini monovision, you can get even a little better for reading.
A little bit better.
If this is an issue, go a little bit stronger lens.
Has any one of you put these lenses into younger patients, under 30 years old, with cataracts?
Yes, I did.
And?
The results are excellent results like trifocal lenses.
Yes.
Yes, I have very good results.
Jaeger laser, but that's...
I have one such patient, and so I'm asking him, how is it to see from far to near? And he looks at me, what are you asking me about? He never had presbyopia, but he's never bothered by his lack of defocus now that he has an intensity in. So that's very funny. He doesn't understand what I'm asking him because the simulation of the real situation is so good in his eyes.
And I put it in one patient with less than 18-year-olds because he used a lot of corticoids. Well, I have very good result. I don't present now, but just in one eye with very, very good result too. For far and for near and for intermediate. He feel like the same with another eye.
Thank you. Thank you. Your last chance today to ask us anything you want to know. That's it. Thank you very much for coming. I'm much impressed with the amount of people who are here. Thank you very much.